Um, Thank you very much, Dr. Mujahid, and Assalamu alaikum, everybody, and welcome to the COPD seminar that we have arranged for you today. And Dr. Sahel has been instrumental as ever in bringing together some really important parts of COPD management, which are sometimes missed in the other talks, particularly around World COPD time. And I think this is so important to bring forward all the important aspects of COPD because already it's a Cinderella diagnosis as far as the grand scheme of medicine, medical landscape is concerned. And we need to bring more attention and more interest into this area so that general practitioners in particular will be able to spot and recognize ways to manage COPD. And unfortunately, we're always very pharmacologically focused because we like to be able to satisfy our patient that they want to have some kind of pill or some kind of medicine that's going to make them feel better straight away. Actually, there's a lot of evidence, as Professor Irfan has shared, that non-pharmacological treatments have a huge role in chronic diseases such as COPD. And pulmonary rehabilitation is one of them. So just wanted to share some of the background around pulmonary rehabilitation with you today, and also our experience in setting up a multidisciplinary service at the Indus Hospital. So just to declare no conflicts of interest, and to explain that this presentation is going to look at what pulmonary rehabilitation is, if there's an evidence base, setting it up, and then our Indus experience. So just looking at the definition of pulmonary rehabilitation, it was first established by the ATS and the European Respiratory Society Working Group on Pulmonary Rehabilitation in 2013 and has recently been re-endorsed last year. It's a comprehensive intervention that looks at a patient after a thorough assessment where patient-tailored therapies are put together that focus on exercise training, education, and behavioral change, which look just not at the physical aspect, but also the psychological conditions of the people with chronic respiratory disease. Bear in mind that this definition is for chronic respiratory disease, not just COPD. And the idea is to promote long-term adherence to health-enhancing behaviors. Pulmonary rehabilitation is particularly helpful in those patients who have COPD, bronchiectasis, interstitial lung disease, chronic asthma, post-infectious lung disease. We're basically looking at a group of patients who are defined by their breathlessness. And this is looking at this concept that Professor Irfan introduced of treatable traits, looking at symptom control and focusing on that. And in fact, 10% of the world's population would benefit from pulmonary rehabilitation. The idea behind it is that the breathlessness that's caused by chronic respiratory disease, caused primarily because of a low oxygen state, providing insufficient oxygenation of muscles, causes dyspnea when the patient is moderately exerting themselves. They then abstain from exercise, which causes more physical deconditioning, and as a result, even more dyspnea, so that they're breathless even when they're exercising mildly. This is a spiral that causes a lot of problems for the patient because ultimately they're not able to do their activities of daily living. And so it's not just the disease, but its complications that have caused them to be so symptomatic. So pulmonary rehabilitation has been looked at from a evidence perspective, and a number of ways that it contributes to health have been found. So most importantly, exercise capacity significantly improves compared with usual. And the best evidence is in COPD, where exercise capacity has been clinically significant in its in the difference that's been made by pulmonary rehabilitation. Similarly, dyspnea and the health status, as well as some other aspects such as physical activity and ability to do activities of daily living have also shown improvement after a course of pulmonary rehabilitation. Muscle strength has been measured. In particular, quadriceps are measured in patients with COPD, and after a course of pulmonary rehabilitation, the strength has been found to be better. Patients have a better approach in terms of their psychology towards disease, their nutritional status, as well as their ability to manage themselves, i.e. their self-efficacy, because of the psychological and educational components behind pulmonary rehabilitation. And what about mortality, which we talked about? I'm sharing evidence for stable COPD. There are a couple of trials that were a little bit controversial. The 95 REES trial included COPD asthmatics that were stable with no other medical conditions, whereas the Griffiths trial in 2000 defined COPD patients as having an FEV1 of less than 60% with no reversibility. And when you compared the rehabilitation offered to these groups, you found that the survival was very good in the pure COPD group. So the Griffiths trial showed that after a year, rehabilitation group had a better survival outcome. There have been other trials since then as well, but COPD patients certainly seem to benefit when you offer pulmonary rehabilitation straight after a COPD exacerbation. And this this sort of meta-analysis done by Ryersol and colleagues shows that there is a survival benefit when pulmonary rehabilitation is offered right after an exacerbation of COPD. So coming on now to multidisciplinary pulmonary rehabilitation. We have lovingly called it at the Indus, we call it PURE, to capture all its multiple facets. We have particularly focused on mental health support as well as physical exercises and strength training. We focus on nutritional advice and patient education. And to date, since 2018, when we set it up, 150 patients have completed the entire pulmonary rehab course, and 28 patients are undergoing it now. So it may not seem like large numbers, but actually pulmonary rehabilitation is a 6-week course, and patients come to the hospital 3 times a week. There are multiple challenges in convincing patients to come and complete the course as well. We've also been disrupted by COVID when we had to close our service altogether. The patients that we saw mostly between the ages of 40 and 70. And interestingly, most of them are females, although a lot of our other Indus data shows that COPD is more commonly diagnosed in males than it is in females. But there may be something about the dynamics of females coming to pulmonary rehab sessions that makes this number the way it is. Women generally, once they make up their mind about something, will definitely go through with it, but also don't have to go to work after they start feeling better after a few sessions. We've offered COPD to all breathless patients. Majority of them have some sort of obstructive lung disease, such as COPD or asthma. Some of them had bronchiectasis, and another group had post-TB sequelae coming from the TB clinic. We offered pulmonary rehabilitation to a few post-COVID patients as well, and in fact, they did incredibly well. So I just wanted to share a few of the challenges that we experienced in setting up our service. Pulmonary rehabilitation and its concept of involving lots of different kinds of disciplines did mean that we had to coordinate with multiple teams. And this was not always easy. I think now our physical rehabilitation center and the physiotherapists at the Indus Hospital are completely sold on pulmonary rehabilitation. We've got Danish here to support that. But actually, at the beginning, it was very difficult to convince them what the role of this was, because there's very few pulmonary rehab centers in Pakistan, and they were very focused on orthopedic rehabilitation. So moving away from that has been a challenge. And so involving nurses for education purposes and nutritionists to talk about COPD in particular has been very interesting, but initially challenging, and now incredibly successful. We wanted to collect our data very carefully because obviously it's a new area, and so we used digital data collection methods and used REDCap for this purpose. We wanted to improve patient compliance and adherence, so we supported them with transportation facilities. The other thing that was very interesting was difficulty in arranging a formal referral system within Indus Hospital to the pulmonary rehab service. And now we have incorporated this within the hospital medical information system, the HMIS, so that doctors can refer to pulmonary rehab straight away. But in fact, raising awareness amongst physicians is an ongoing process, and I hope today's session will help you to spread the word amongst others that this is an incredibly important area that can benefit patients significantly. And even at Indus, even now, outside of pulmonology, there are very few referrals made from internal medicine and family medicine to pulmonary rehab services. So space may not be an issue in some places, but at Indus, space is a premium, and we always have an issue around this. But hopefully, this will change in the next few years. We specifically looked at how transport was affecting adherence because it's expensive to provide support to patients from a long distance. But actually, we found that we have very much improved adherence when we offer transport compared to when we don't. We also find that patients are more likely to initiate pulmonary rehab if they know that they would have transport support. So in blue in this chart, you can see all the patients that have been using the van to come to our services. And the percentage is, at least 50% or more. We've been measuring patients' symptom status at the initiation of pulmonary rehab and then on completion, and find that in these 138 patients, we found the average MMRC score significantly improved, and that their 6-minute walk test had improved as well. And you can see here the average goes from about 180 to about 300 meters that they can walk. So obviously for those incredibly breathless patients who come to see us, it's a huge difference in their life that they can walk about 100 meters or more. So I have a little bit more information about nutritional support because we brought on a very focused and very motivated nutritionist who has been basically been given the task of determining how to measure the impact of her nutritional support that she offers. So she has been specifically counseling on awareness of nutritional health, importance of a healthy diet, active lifestyle, good sleep, and health impact, and would give individualized advice to patients depending on their nutrient diaries, on whether they need high protein foods, such as, and this should be diversified, by the way, and not just animal, but also plant-based proteins, and to reduce their carbohydrate intake. And then help them with strategies to include and diversify their meals from different food groups. At the Indus Hospital, we have a lot of patients from low-income groups who cannot afford multiple different kinds of food types. And so this is an incredibly challenging area for the nutritionist because patients can't always afford to have different and the best nutritious diet. But nonetheless, she records their appetite levels, the meals they consume per day, and measures their diet diversity score, which in the world of nutrition is a form of measuring nutritional intake. And she's found that after 4 sessions of nutritional support, that their diet did become more diversified. Appetites are improving by 93%. Along with the exercise that they're doing, and patients are consuming more than one, adding more than one meal to their diet diversity. So they're not just focusing on 2 meals a day, they're having 3 meals a day. So this is really important in terms of building up their nutritional welfare. Mental health counseling, another area that we give at least 4 sessions to every patient. We know that most patients with chronic disease, not just COPD or chronic respiratory disease, are more likely to have anxiety and depression associated with that and have difficulty coping with their chronic disease. So our counselors are specifically looking for those patients who have problems that their lung disease is bringing into their life and trying to help them apply the most feasible interventions to alleviate this. They measure the AKU adds on presentation and then work with the patient in talk therapy to try and improve the way that they can manage this. Their AKU add score is usually in the medium range. So the red one shows the pre-pulmonary rehab number, and it's a little bit higher than when they finish. So there's definitely some impact being made there, and what we've found that it's difficult to increase the number of sessions beyond 4 for the patients, but those who need it get transferred into the mental health services at Indus Hospital so that they can have ongoing support. When we were setting up our service, then we looked at whether we have achieved what we wanted to in improving quality of life for the patients who have come to us with chronic respiratory disease. And so we applied a local version of the St. George's Respiratory Questionnaire. By local, I mean the Urdu version, and found that the intensity of symptoms, the impact on social life, and activity scores all significantly improved after patients went through pulmonary rehabilitation. So this was a win-win for us and for the patients, because a significant impact was being made. We've started taking patient feedback about what they think about the service that they go through, because obviously they put in a lot of energy to this. They are coming frequently for several weeks, and we need to know that they're satisfied with it. Certainly, many of them, and these are sort of the bigger the balls, the more people said these things. Many people said that they breathe better. They can do more activities of daily life. They found the whole experience relaxing. They felt exercises were good, the van was a good thing, and that the staff was helpful. Some people said that it improved their health and it gave them proper guidance. And other people said that it would be better if we had a bigger space and we had more equipment to conduct this. Last year, around December last year, we had 100 patients completing pulmonary rehabilitation. So we made a video of the 100th patient, and here's a little clip of that so that you can hear from the patient themselves.
मेरा नाम सैमुअल है। मैं बहुत बीमार था, हॉस्पिटल में आया हूँ इसी में ही। फिर वो डॉक्टर के पास गया हूँ, डॉक्टर साहब ने मेरा इलाज किया है, तो मैंने बहुत फ़र्क पड़ गया, बहुत अच्छा हो गया हूँ। फिर उन्होंने मुझे डॉक्टर फरानाज के पास भेजा है, डॉक्टर साइमा ने। तो इन्होंने मुझे फेफड़ों की वर्जिश के लिए यहाँ रखा है, तो मेरा इलाज कर रहे हैं। ये भी बड़ी अच्छे तरीके से मेरी अपना फेफड़ों की वर्जिश करा रहे हैं। तो मुझे इन्होंने गाड़ी दी है फ्री कि मुझे लेके आती है, छोड़ के आती है। मैं बहुत शुक्रगुज़ार हूँ इस हॉस्पिटल का, बहुत अच्छा हॉस्पिटल है। पहले मेरी कंडीशन ऐसी थी कि मैं बिल्कुल ही चलना फिरना मेरे लिए आसान नहीं था। अब मैं थोड़ा सा भी चलता था तो मेरा सांस फूल जाता था। अब मैं जहाँ से दिल चाहे मैं वहाँ से तक यहाँ आ सकता हूँ। अभी भी मैं थोड़ी देर पहले ये नीचे गेट के पास खड़ा था, यहाँ तक मैं ऊपर तक आया हूँ, मेरा कोई सांस नहीं फूला। मैं बिल्कुल सही ठीक ठाक आया हूँ, अभी आपके सामने बैठा हूँ, मैं बिल्कुल ठीक हूँ। मैं ये डॉक्टर सैमा का, डॉक्टर फरानाज का, ये जो उनके लोग हैं और फिज़ियोथेरेपी वाले, इनका भी बहुत शुक्रगुज़ार हूँ। खुदा इनको बहुत खुश रखे। अच्छे हैं, बहुत अच्छे हैं सारे, बहुत गाइड करते हैं। यहाँ गाड़ी वाड़ी भी उन्होंने दी, सारा कुछ किया, बहुत अच्छे लोग हैं। हॉस्पिटल भी बहुत अच्छा है, खुदा इसको बहुत बड़ा हॉस्पिटल बनाए।
So that's just to give you an idea of how people are talking about us, and we're very excited about that because even though it's not one of the biggest programs, those people who do complete it really have a huge impact on them, and that's kind of the message that I wanted to get across. Pakistan needs many more pulmonary rehabilitation centers. It really is an evidence-based, and we have the evidence at Indus Hospital amongst a very disadvantaged socioeconomic group. It's a multidisciplinary intervention, so it's a great way to work together, and it really changes lives. It's underutilized in Pakistan at the moment, but it can really change morbidity and mortality of this disease. I particularly wanted to thank the pulmonary rehab team because it's very much a team effort. In the picture with me here is the physiotherapists, Farah, who Samuel, the patient, mentioned in the yellow dupatta and scarf. Standing next to her is Danish, Samuel, our lung health nurse, and right next to me is Rehma, who's our research associate, and on the right-hand side is the mental health counselor, Shamaila, the nutritionist, Masuma, and one of our other mental health counselors at the end. So they're really the movers and shakers when it comes to pulmonary rehab, and they're the ones who've made it all happen, because I don't think that just giving them inhalers on their own would have made this kind of difference for them. So that's it. I've just put a plug for our petition on novel tobacco products. If you have a minute, then please take the time to sign it. We want to try and get it banned. Please feel free to do that now. Otherwise, if there are any questions on pulmonary rehab, then please let me know.